Good morning. Welcome to Americans Are Angry About Their Health Insurance, the Movement for Single Payer. This webinar is being brought to you by Health and Medicine Policy Research Group. We are a Chicago-based advocacy group that has been around for over 40 years, working to ensure that everyone has access to high-quality health care. I am Dr. Claudia Fegan, recently retired Chief Medical Officer for Cook County Health, and a long-term board member for Health and Medicine, as well as the National Coordinator of Physicians for a National Health Program. I'll be your moderator for this webinar. I want you to know that we have real-time Spanish interpretation available for this webinar. In the webinar controls at the bottom of your screen, you need to click on interpretation next to the globe icon. You may not see interpretation. You may see a circle with 3 dots and more underneath it. And if you click on that circle, you'll see the opportunity to click on interpretation. Click on the language you would like to hear. To hear only the interpreted language, click to mute original audio. You may switch between languages at any time. And with that, I think we'll get you started. The tragic murder of a health insurance executive released a torrent of frustration and anger from people across the United States. Hundreds of people took the opportunity to tell their stories of the difficulty getting care they needed because it was denied by their insurance company. We find ourselves wondering why a 50-year-old was gunned down on a busy New York street. We should be asking why it took so long to hear the pain of so many. The insurance industry profits by spending as little as possible of the insurance premium dollar on the delivery of health care. Consequently, they have built a tremendous infrastructure designed to question clinical decisions by physicians and questioning the indications for medications, tests, or treatments ordered by healthcare providers. We can't blame the insurance companies. It is our failure as a country to provide universal health care for all who live here. And with that, I'll start with our slides. We need to fight, why we need to fight for single payer. The private health insurance industry has never controlled cost or improved the health of the people served. I have no financial disclosures. And I would tell you that the number one reason for bankruptcy in the United States today is a result of medical illness or medical debt. And the question that this raises is, what is the role of insurance when the overwhelming majority of people who declare bankruptcy as a result of medical illness or medical debt have insurance at the time of the inciting illness? Next. Next, please. We have fallen behind other countries in terms of life expectancy. And while life expectancy around the world went down with COVID, other countries have recovered, and we have failed to make significant improvement. Next. Next, please. We spend more on healthcare than other wealthy nations. Next. And if you look at the different financial models around the world, there is the National Health Service, which is socialized medicine, public funding with public delivery. There is National Health Insurance, which has public funding and private delivery. And there is the Bismarck model, or all payer, which has a mixed funding and private delivery. Many people think this would be the closest to what we have, but it is highly regulated. And these companies, different insurance providers, compete not on benefits, but on amenities such as health club memberships. And then we have the United States. We have multi-payer with mixed funding and mixed delivery. And if you look at these different models, all of them are successful in providing coverage to virtually everyone. And the United States, while we leave almost 15% of the population uncovered, we leave another significant portion of the population undercovered, meaning they have coverage, but the result of an illness can result in bankruptcy and medical debt. Next, please. We also have struggle with the provision of primary care. All of the other models are far more successful in encouraging physicians to go into primary care, which becomes financially undesirable in the United States, where the other costs are so high that primary care physicians feel it is not sustainable. Next, please. If you look at, if we were to convert to socialized medicine, it would be 70% less expensive than the United States. And their results or outcomes are excellent, if not better than ours. If we were to go to national health insurance, an improved Medicare for all, it would be 50% less expensive than the United States. And the results, again, are excellent. Obviously, longer life expectancy. Even the all-payer Bismarck model is 40% less expensive than United States with good outcomes. And so what we have in the United States is the most expensive plan with the most uninsured and the shortest life expectancy. If you look at the United States and Canada, in 1970, the United States and Canada spent approximately the same percentage of their gross domestic product on healthcare, and we had similar life expectancies. Since then, in 1973, we signed the HMO Act was signed into law, which was thought that it would bring managed care to the American population and that it would save cost and improve access to care. Similarly, in 1971, Canada fully implemented Medicare. I will remind you that Canada had the term Medicare first and that Lyndon Johnson borrowed it when we created Medicare for insurance for people over 65. They began to cover in 1971 everyone. Since then, our cost of healthcare has continued to increase. If you look at the impact of the addition of the HMO Act, and the implementation of Medicare by Canada, their healthcare cost, while rising initially, eventually leveled off, and we have continued to climb. If you look at the percentage of healthcare dollar that goes to the delivery of care, as opposed to the percentage that is spent on administrative issues and profits, in Canada is less than 2% on administrative cost. Traditional Medicare in the United States is less than 3%. But private insurance and the new Medicare Advantage plans all take significant portions of the healthcare dollar for administrative cost and premiums and profits. And while we estimate that it may be 5%, 15% of Americans who are uninsured, it depends on how you ask the question. If you ask, were you uninsured at any given moment, any uninsured any given month, it's 11.2%. If you ask if you're uninsured at some point over the past year, it's almost 17%. And if you ask, were you uninsured at any point over the past 2 years, it's over 20%. And then if you look at those who are not covered by Medicare, the non-elderly, people under the age of 65, have you foregone any care in the past year? It can be between 10 and 15%. Did you go without needed medicine due to cost anytime in the past few years? It's between 5 and 10%. And did you go without needed medical care due to cost? Also between 5 and 10%. And did you go without needed mental health care due to cost? While it's maybe less than 5% a lot of the time, since COVID, it has definitely increased to more than that. And I cannot have this conversation about healthcare in the United States without talking about the results of the overturning of Roe v. Wade, the Dobbs decision, where significant swaths of the country now have to travel more than 180 miles for abortion care. The average driving distance to the closest abortion provider before and after Dobbs has increased dramatically. The repeal of the Dobbs decision has resulted in many more people foregoing abortions and increased pregnancy-related deaths, as well as increased postpartum hemorrhages. But if you look at high-risk states where there are no exceptions for abortion care, whether personal decision or medically indicated, we see that these numbers are dramatically worse. More women are dying or suffering complications of results of pregnancies that might have been foregone in the past. And we have to talk about Medicare Advantage, because Medicare Advantage is a private managed care version of Medicare. And now, as of June of 2023, the majority of Americans in this country who are on Medicare have Medicare Advantage plans. These plans are dramatically overpaid, some estimates up to as much as $140 billion a year. And this is done by cherry picking healthy beneficiaries and coding aggressively diagnoses to increase the amount of money they receive from CMS to provide the care. And the question is, how is this possible? How is it that we are paying more for healthier patients? Medicare Advantage beneficiaries tend to receive less care, health care, than traditional Medicare beneficiaries. And the providers who provide care for patients, whether they are in a Medicare Advantage plan or traditional Medicare, are compensated the same. But Medicare Advantage plans receive much higher payments than traditional Medicare. So how do we account for this paradox? Medicare Advantage plans have higher overhead, administration, and profits than traditional Medicare. And we need to be clear about this, because profits are not the majority of the overhead for Medicare Advantage plans. These plans have very high administrative overhead. We know that in a given year, Medicare Advantage plans had over 50 million prior authorization determinations. These determinations can be for anything for a prescription to seeing a specialist or additional care. They are used for more complicated care, more expensive care. And what we know about during the same time period, traditional Medicare had only 400,000 prior authorizations. And what does this mean? It means that in Medicare Advantage, there are an average of 2 prior authorizations for every enrollee, whereas traditional Medicare, there may be 1 prior authorization for every 100 enrollees. And the problem with using this prior authorization process In the Medicare Advantage plans, we have found that less than 12% of the denials from prior authorizations, where care was denied, prior authorization was required, and the care was denied, less than 12% of the time, the recipients appeal that. However, when they do appeal, over 80% of the denials are overturned. The problem is people get frustrated, give up, and don't appeal or don't realize they have the right to appeal. When they don't appeal these decisions, the care that was denied becomes pure profit. This is money into the pockets of the private insurance industry that uses prior authorization as a way of limiting or decreasing utilization. Next slide, please. Julian Tudor Hart, famous English primary care physician, said, the availability of good medical care tends to vary inversely with the need of the population served. And he warned us, the more health services can be removed from the force of the market, the more successful we can be in distributing care away from its natural distribution in a market economy. Next, please. Next, please. Medicare means healthier Americans because it provides access to care. If you compare the United States with 16 other wealthy countries, what we have found over time is that we tend to rank near the bottom in terms of the health of our population. However, something magical happens at 65, because at age 65, people then have access to health care through Medicare. And what we find is that with that coverage, our population health improves. So that if you make it to 90, you're sure to be we're the healthiest population in the world. We know that single payer with global budgeting could reduce the 10-year hospital spending from 17.2 to 14.7 trillion. How could we do this? If we look at the current trajectory of hospital spending, and then we look at a single payer hospital trajectory. And single payer spending, if costs increase, if we had no increase in utilization. How we know with single payer there will be increased utilization, but also with that increased utilization, we will have increased quality improvement with single payer. And if we don't have to have the marketing and the profits, you see the constant commercials urging people to enroll in different plans. And instead that goes to healthcare. And the administrative savings by not denying so many people the decisions of their clinicians, as well as the reduced growth rate. We know that we could save money with a single payer national health insurance. Single payer Medicare for all, we would look to have an improved Medicare. All medically necessary care, inpatient, outpatient, prescription drugs, mental health, dental and hearing, vision, long-term care, and comprehensive reproductive care, because abortion care is indeed health care. There would be no co-payments or deductibles or premiums, because we know co-payments as low as $1 or $1.50 will deter people from necessary care just as often as unnecessary care. That was demonstrated by the Rand Corporation in the 1970s. And no need for supplemental or Medigap insurance that would be equitably funded through progressive taxation. And it's important to say that nobody would be left out. We do not need to spend the money to determine how each person will pay for their care. And that includes everyone residing in the United States, regardless of their age, income, employment, or immigration status. and people would be covered reliably for their entire life without disruptions when they change jobs or employers change insurance. And no one would be denied due to pre-existing conditions. Patients would have freedom of choice to practically any doctor or hospital that they would choose. And as we look at what we have done over the last 50 years in higher income countries, while life expectancy at birth has gone up around most of the world, we keep attempting to reinvent the funding for healthcare, saying that it will improve access. And yet we continue to drift further and further away from the rest of the world with various plans. All of the other countries have some form of national health insurance, and we go through the HMO Act, Medicare Plus Choice, Medicare Advantage, the ACA, the DCE, and REACH, and none of them have done anything to improve life expectancy or decrease the cost of healthcare in the United States. So I would say about the grand experiment, if we compare the United States to Canada, we spend twice as much as they do for fewer years. Medicare for All protects hospitals by creating global operating budgets. So if we look at hospital financing today versus Medicare for All financing, hospitals chase procedures that are profitable. Hospitals invest in profitable services and discontinue those that are not, and they optimize their billing. The pandemic created a fiscal emergency for hospitals when we needed them more than ever. Medicare for All would have predictable negotiated annual global budgets for each hospital, greatly reduce the overhead, ends the hunt for profitable interventions, and aligns resources with the healthcare needs of the community being served. We could do this. PNHP has available to you on from our website, our payments, their profits. And with that, I'm going to introduce our next speaker. Thank you. Dr. Monica Maalouf is a primary care internist and assistant dean of diversity, equity, and inclusion at Loyola Stritch School of Medicine. Outside of her role as a faculty member, she is co-president of Illinois Physicians for a National Health Program and on the board, a board member of Illinois Single Payer Coalition. She is going to speak about what activities are happening around single payer in Illinois. Monica, welcome.
Hi, thanks for that great introduction, Claudia, and thanks for having me, and thanks for everybody who's tuning in today. I think this is a very timely and an important conversation, and one that we are going to continue to have over the next several years. In my role in Illinois, I help co-chair the Illinois chapter for Physicians for a National Health Plan, and we're doing a lot of advocacy at this moment to try to really engage with our Congress people and our elected representatives about what's happening with privatization. I will say that every 3 to 6 months, we pick a different avenue of advocacy. We kind of pick a different goal, and we work as a chapter to work towards that goal. So right now, we have several meetings set up with representatives, our congressional representatives in Washington, including with Jan Schakowsky, Mike Quigley, Sean Casten. So we have some meetings set up this month, and really the goal of those meetings is to get our representatives on board with the data and the harms of privatization. I think what we see, a lot of our people in our organization are either physicians, pharmacists, or nurses, and we really see firsthand the harms of what's happening and how privatization has affected our patients, especially in the Medicare Advantage space. So through these meetings, we're hoping to engage our politicians on these issues and then encourage them to sign on to letters supporting universal health care. Right now, Congresswoman Pramila Jayapal has a letter circulating in Congress about Medicare for All. So we're encouraging them to sign on to support that letter. So that's a little bit about what we're doing right now. We constantly have activities going on. We're also engaging with other partners in the Chicagoland area, including People's Lobby and other people involved in the health advocacy space. So if people would like to get engaged or get involved, what I'll do is I'll share my email in the chat. People can always reach out to me and I can talk to you about ways to get involved with any of those organizations doing that work. And I'm happy to answer any questions about that as well.
We're going to hold questions to the end, but I'll go ahead and introduce Bill Bianchi, who has been active in the single payer movement and Illinois Single Payer Coalition for more than 15 years. He was elected board president of Illinois Single Payer Coalition in 2023, and he is leading Illinois Cities for Single Payer resolution campaign, which seeks to get cities and counties across Illinois to pass resolutions supporting Medicare for all. He's going to talk about how you can get involved in this movement.
Hi, everyone. Thanks for having me. Thanks to Health and Medicine for having me. Illinois Single Payer, as far as I know, Illinois Single Payer and PNHP Illinois are the only groups in Illinois dedicated to Medicare for All. And I want to tell you a little bit about Illinois Single Payer and our current campaign, and then I'll go into how you might get involved. Illinois Single Payer is an all-volunteer organization. We occasionally have a consultant, but we're volunteer-led and volunteer-staffed. However, we do recognize that to expand our activities, we're probably going to need a full-time executive director. And so we're working toward that goal over the next year and a half. Our activities and programs, prior to COVID, we did educational programs mainly and speaker training. I think one of the most interesting educational programs we did is we sent a letter to every county Democratic Party in Illinois. I think there's 103 counties in Illinois. I don't know why we need that many counties, but anyway, we do. And out of that, we got something like 10 invitations to speak, 8 or 10 invitations to speak. And I thought those were very, very productive because we were talking to grassroots people who were politically active. And so they, have contact with a lot of people. And they're very pertinent people to as far as, spreading the word about Medicare for all. We've also done some lobbying within the limits of a 501c3, which is what we are. Our current campaign, as was mentioned, is the Illinois Cities for Single Payer. But another important aspect of our work, which pops up now and then, is working with LIs on health-related issues. For instance, on Chicago for abortion rights. As Claudia mentioned, abortion is part of reproductive health care, and health care is health care. The Alliance for Community Services we work with, and their work to improve the experience of elderly in nursing homes, and of course PNHP. I could go into maybe some of you remember about 4 or 5 years ago in June when we had the demonstrations outside of the AMA. That was a good example, successful by the way, and that was a good example of how collaboration with allied groups can really increase our power. So Illinois Single Payer, Cities for Single Payer, the current campaign. As I mentioned, the idea is to get city councils, county boards, or even township boards. I didn't know much about township boards, but there's a lot of them out there, to pass a resolution in support of improved Medicare for all. And then to take that and use that to tell our congressional representatives to sign on to the Medicare for All bills in Congress and advocate for their passage. Now, you may know that our previous, the previous Congress had a great bill in the House and a pretty good bill in the Senate. And we had a number of Democrats that signed on, I think over 100. But now a new bill has to be implemented. And so we're going to go out and try to get those, make sure those same people sign on and add to that thing. So you may, Chicago, we think should be on that list. I think, oh, excuse me, I'm sorry. This is part of a national campaign that is being organized by Public Citizen, the Ralph Nader group. And yes, Ralph is still around, believe it or not. So they've organized the National Resolution Campaign, and I believe they have over 100 cities and counties that have passed resolutions. And just 2023 or 2024, we had Austin, Texas, Baltimore, Maryland, and Cincinnati sign on. We think Chicago must be on that list. We would be the largest city if we passed a resolution. We have a very progressive base and a progressive city council. So there's no reason why Chicago should not be on that list. Now you may be asking yourself, so what is the exact purpose of a resolution campaign? Well, as I mentioned, about half of the House Democrats have signed, the most progressive members have already signed on to the Medicare for All bill, and getting additional signers will be challenging. So the resolution campaign will help build the strong grassroots movement that we need to get more congressional support. The resolution campaign builds awareness, it educates the general population, and it gets media coverage. And those are things that are very valuable in our struggle. Most important, though, it educates and motivates local legislators. So far, we've talked to, I don't know, maybe 15 or 20 legislators who we never about Medicare for All. And so we're keeping it in front of them. Some of those people will go on to be congressional representatives, and hopefully they'll have taken their lesson with them. So our plan is we're going to start in Chicago, which is the logical place, and then move downstate. If we can get down both some cities downstate, I think it'll be a major step for us, because it'll be hard for the media to ignore, which they do a lot of now. Okay, so let me tell you a little bit about the Chicago Resolution Campaign. We started last year in March and worked through up to the election, and then nobody wanted to talk about anything except the election at that point. So, and then with the holidays, we suspended it, and we're starting right now. The murder of the United Healthcare executives has certainly refocused attention on healthcare and the need for some great improvements. At this point, we have 10 older people who have signed on and 4 organizations who have endorsed us. We hope to get the entire City Council Progressive Caucus, 19 people, to sign on soon. And we have every reason to think that they will do en masse approval of us. When we get, well, I think when the new bill is introduced, we will then want to have a hearing in our city council by the health committee on this resolution. And we've already gotten approval from the chair of the city council Health and Human Resources Committee to hold that hearing as soon as we find out when the Congress will introduce a new Medicare for All bill. So the chances for our succeeding look pretty good at this point. Now, downstate, we want, of course, more cities and counties to pass resolution campaigns. We were once told by somebody in Durbin's office that when they see, the public complaining about something or protesting about something, and they see that's Chicago, they kind of like, yeah, well, of course. But when they see it from downstate, they pay a little more attention, because that's part of their constituency that they don't think is very progressive. So getting some small towns around, and we have some pretty good prospects. Bloomington, Champaign-Urbana, Rockford, Aurora, and I think Lisle Township. So we've made a little headway in getting it. And if we do get the some cities around here, I think we'll have a pretty strong argument that Illinois supports Medicare for All. And I want to just make a statement before we go into how to get involved is PNHP has introduced their three-pronged strategy, and I really think it's brilliant. They want to stop and reverse privatization of Medicare and Medicaid, and I think they call it stop profit from healthcare or something like that. And of course, that's essential that we have public insurance programs that we can tell the public, this is what public insurance costs, this is what private insurance costs, and people can see the difference. More important, I think, is it to improve traditional Medicare. Because Medicare, as good as it is, I'm on traditional Medicare, it has a couple serious flaws in terms of cost and coverage. If we can improve it, we help create a model for Medicare for all that enables us to fight more powerfully. Because we can say the seniors have this great program, shouldn't everybody have it? Why should it be limited to just the seniors? And I think it makes it a lot easier for people to understand single payer if we could say it's just like Medicare, and Medicare has a good reputation. So we're going to try to work as much as possible with PNHP during the coming year on improving Medicare for all and stopping privatization. Okay, so how do we get involved? Kind of depends on where you live. If you live in Chicago, the first thing, of course, is to join and support Illinois Single Payer Coalition. But if you live in a ward where the older person has signed on already, and we have 10 of those, we want to congratulate and promote, congratulate them. In fact, just call them up or send an email and say, thank you for doing this. We really think it's important. That has a bigger impact than you might think. And also to promote it on your social media networks. Let people know that what the alderman has done. If there is local media, local newspaper, please contact them and let them know. And then when we hold the hearing in the city council, try to attend and let your older person know that you're going to attend. So that's for the people who live in those 10 wards, which I think will be 11 pretty soon. Next slide. If you're outside of Chicago, you've got a little bigger job because we're asking people to start a local resolution campaign. And that involves, you may not think of yourself as a leader and that a local leader, but that's really where the action is right now in terms of building support, is at the local scene. So the steps are pretty easy. We'll go through them here quickly. One is we want to host a introductory virtual meeting. And that means working your networks, anybody you think might have an interest, and inviting them to a virtual meeting to talk about a Medicare for All resolution. And the people who show up are people who are interested, right? And the purpose of the meeting, though, is to form a steering committee that will guide the resolution campaign in your area. The next thing the committee does is to write the resolution document. It's not difficult. There are a lot of models. And then after that, reach out to any local organizations that might be interested. And these include organizations of racial justice, more progressive churches, and local Democratic Party. And then at that point, you can start meeting with legislatures. Illinois Single Payer and People's Public Citizen can provide guidance and resources every step of the way. We have models of resolution documents. We have suggestions for how to get appointments with legislators, what organizations support Medicare for All. So we can provide a lot of help. You won't be doing this alone. Next slide. It's really important, we think, to collaborate with allied groups on their issues if they are health related. So some of the groups that we're involved with now are Jane Addams Senior Caucus, PNHP, of course, the Alliance for Community Services, the People's Response Network, H&M, of course, and as I mentioned, KFAR, People's Action and Access Living. unions. We have not been too successful in cracking unions, but they're a great target. And if we had more progressive unions, we'd have a lot easier job. Faith-based groups, churches, synagogues, temples. So I want to talk about just a second about People's Action. People's Action does, like many groups, does support Medicare for all, but it focuses its action on claim denials. And this has turned out to be a very powerful tactic, because we know that denials are an important part of the business plan of our health insurance companies. And I think my approach has been to work with them on this and then say the best way to stop claim denials is not through regulation, because regulation can always be manipulated. It's to get rid of the insurance companies. And the way we do that is Medicare for all. So in that way, I've tied Medicare for all to People's Action's work on claim denials. Okay. I want to mention just in passing some of the national single payer groups. I'm sure you've heard of some of them at least. National Nurses United. I mean, they are the largest and most powerful nurses union. They have been dedicated to Medicare for all for, I don't know, how many years, Claudia? 20 years, 30 years.
More
And
than
they have an interesting program going on right now. And so if you wanted to hook up with them, that would be fine. Healthcare Now is collecting stories of, the trials and tribulations of people on our private insurance. National Single Payer is, I believe, planning to hold or sponsor a march on Washington sometime in the spring or summer in favor of Medicare for all. And I'd certainly want to be part of that. And then, of course, the Physicians for National Health Program, with their three-pronged strategy, want to pay close attention to that. So those are the many ways that get involved with Medicare for all. And if you want to reach out to Illinois Single Payer, you can reach me at bill@ilsinglepayer.org. I want to say finally that the issue for discussion, or something to keep in mind, on the next slide, and that is our relationship to political parties. We've been working with the Democratic Party for a number of years now. I think the consensus is that the rank and file members of the party do support Medicare for all, but the leadership does not. And probably because of all the money that comes into them. So what do we do about that? How do we move the leadership a little bit, at least, to not be hostile to Medicare for all? And I'm suggesting maybe we can learn from the right. They developed grassroots movements through the fundamental churches, and that enabled them to dominate the Republican Party. We have to learn how to develop our grassroots movement so we can at least be influential with the leadership of the Democratic Party. So we have to build a larger progressive grassroots movement that can either dominate the Democratic Party or, if necessary, work with a new party if one arises. Thank you very much. I really appreciate the opportunity to speak.
Thank you, Bill and Monica. Now we'll take questions. The first question was about, is the single payer healthcare, is it possible without overturning Citizens United campaign finance reform? And so that's absolutely right. Nobody believes that we'll get single payer without campaign finance reform. The reality is that there are three healthcare lobbyists for every single one member of Congress. And that is a powerful force, especially when you realize the billions of dollars that go into contributions. And since most Congress people are focused on getting reelected, those contributions make a big difference and have a tremendous influence. And so regardless of what legislator may tell you, there's a tendency to go with the lobbyist and their interest. But there's another question about whether a state level model of universal coverage, such as Massachusetts, where they have a all payer method, whether that would be feasible. And several Massachusetts has had good success with their all-payer, but you will not achieve the financial savings to cover everyone with a state-based model. I think that the data shows that in order to cover everyone, even those who are uninsured at this point, will require a national change. Do you agree with that, Monica?
Yeah, I think there's a lot of issues with the state-based model. We've seen some issues, kind of some states try to employ it in the United States. I think one is the cost and financing when you have these national insurance companies, and how do you navigate that with patients who are just in the state? How do you define people who are in the state? What happens if people move or switch jobs? So there's like a lot of issues related to that. And then I think Claudia is right that there's a lot of questions about like who would be left out of a state-based plan, and then how that would interact with Medicaid, which is a state-based plan that's funded by the federal government. So sure, that it might be possible to advocate for, and it could be a piecemeal step, but it wouldn't fix a lot of the issues that Claudia highlighted. And so really the only solution that we think is a good idea, which would really answer a lot of the issues that we see in our corporatized healthcare, is a nationwide single payer healthcare system.
Thank you. So there's another question about what we think about solidarity with others struggling with healthcare related issues, such as, and Bill talked a little bit about this, the labor unions and people who are organizing for gender affirming care. And I think that everyone in this movement recognizes there's strength in numbers, and coalition building is important. And Bill, I don't know if you want to add something to that.
Yeah, I just wanted to comment on actually what Monica had said about state-based programs. One thing I've encountered is several people who are very enthusiastic about wanting to work on the state-based program in Illinois. And you know, I don't believe it would work in Illinois or any particular state, but I hate to kind of discourage that enthusiasm that I hear by saying, no, that'll never work. Right? You know, and I wish we had a program where we could say, no, you can't work on this, but here's the best alternative that will, you know, and maybe what PNHP is doing for Medicare, we could devise a program that around Medicaid, which is all state, pretty much state-based, where we could involve people in a fight that would lead ultimately to support for Medicare for all.
Yeah, I think that's a great point, Bill. I think there's a lot, it's important to know that Medicare for all is like the pie in the sky we've been trying to fight for, but there's been a lot of piecemeal reform that we've been able to push for over the last few years, especially as we've focused on attacks on Medicare, because the two sort of social federally supported healthcare systems, we have our Medicare and Medicaid. And there's been a lot of attacks on those programs. And through PNHP, we've done a lot of targeted advocacy to support those programs. And we've achieved some successes. Last year through PNHP meetings with legislators, we were able to stop like a multi-billion-dollar pay increase to private insurance industries through Medicare Advantage. Like I said, we're meeting with legislators. We've had a lot of legislators sign on to plans against Medicare Advantage. So it's not the overall victory, but they're like piecemeal things that we're doing in the meantime, to ultimately keep pushing towards that like big goal.
Yeah, and that's actually what they've done in Massachusetts. The all payer is really Medicaid recipients, and it works for those folks, but we really need to spread that. And I see a question that says they want to be optimistic, but clearly it and single payer is the right thing to do. But hasn't this been going on for decades? Well, I'll tell you that I joined this movement in 1988. So yes, we have been doing it for a long time, but I'll have to remind you that social justice issues do take decades. I'll remind you of the civil rights movement, which we continue to fight, and now we are seeing major setbacks in that. I'll remind you of the women's movement. Again, we're seeing major setbacks in that. So any issue for social justice is never won. It's a continuous and ongoing struggle. And as Monica points out, even in this fight, it has allowed us to make some improvements that are very important for day-to-day delivery of healthcare.
Yeah, if anybody needs to feel a little bit hopeful, I think Claudia, that's a great reframing about Dr. Martin Luther King's quote about the arc of justice is a long one, right? And so I think if anyone needs a good reframing, John Lewis, who passed away a couple years ago, he wrote a book called Across That Bridge. It's a very optimistic look at his 70-year struggle in the civil rights movement. He marched with Dr. Martin Luther King. He was in Congress for many decades. And there's a part in that book, which I'll never forget, where he talks about his fight to build the National Black History Museum in Washington, D.C., which he spent 20 years fighting for, which is like it's so crazy, right? Like just to build a museum for Black history. And he talks a lot about how in social justice movements and in the nonviolent movement, the only resistance that you can have to like barrages of resistance is the only thing we can do is continue to have hope. And so he really talks about how hope helped him through this struggle. And so I think that like part of our philosophy in this movement for single payer is blind optimism. It's like we know this is the right thing. We have to keep fighting for it and advocating for it. We'll take small victories along the way. I agree with a lot of the comments in the chat though, right? Like we are fighting up against like massive corporate interests, Citizens United, healthcare conglomerates. It's an uphill battle, but what other choice do we have but to continue to fight it?
Yeah, no, that's exactly right. And I remember John Conyers introduced the bill to make Martin Luther King's birthday a holiday the year after he was assassinated, and reintroduced it every Congress until it was finally passed. And he used to tell me how people used to, give him a hard time or make fun of him why he was doing this. But he persevered, and we do still have a national holiday. So these battles are very important. Bill, there are several questions for you. They want to know if you will share the 10 wards that have already signed on to the single payer.
Oh,
And they also want to
I
know,
should know that, shouldn't I?
yes, they also want to know if I said you need to get momentum in Little Egypt to get official mass, a critical mass there. And are there any upcoming speakers training opportunities that Illinois Single Payer Coalition will provide?
Right now, we are not doing any speakers training. I think it's something we need to build up our capacity again in that area. There was let's say you asked about the 10. I don't know if I should try to read them off or.
If you have it, you can give the wards.
Okay, so it's a first ward. Do people know their wards that they're in, which
Yeah.
I think is Byron Lopez, I think. The 22nd ward, the 25th ward, the 26th ward, the 33rd ward, which is Rosanna Sanchez, who was the chair of the health committee and very supportive. The 35th ward, Carlos Rosa. The 40th, which is Andre Vasquez. The 46th ward, which is Alderwoman Clay. Her first name escapes me. The 47th ward, which is my ward, Matt Martin. The 48th ward, which is Manny Hoppenworth. And the 49th ward, which is Maria Haddon. If people outside of Chicago, those names will mean nothing to you. But I guess I could how should I do that? How could I put the list? Should I try to put it in the chat, or
You can
but
put
the
it,
chat goes away though when we're done here, right?
it does.
So maybe I could just give it to you guys and you could send it out.
Sure.
That. There was a third question.
The question was about the wards and asked about whether you need to get momentum in Little Egypt to get a critical mass.
Little Egypt? Is that, didn't they call it Cairo, Illinois was called Little Egypt, I think? Is that what they were referring to?
I'm not sure.
Southern Illinois, okay.
Yeah.
I'm not aware of any of well, I would have to look and see what supporters we have down in that area. Yeah, it would be great if we could. It was I should say it was a progressive area around Carbondale, because of the university down there. And it would be great if there was somebody who would like to work on a resolution for the Carbondale City Council. That would be great. Or Cairo, I don't know how you say it, but
There was a question about whether PNHP accepts non-physician members, and we do, but we also are fortunate in Illinois to have the Illinois Single Payer Coalition, which is happy to take all members as well.
Right.
We're all trying to join together in the struggle for this. As I said, this is a social justice issue because healthcare impacts so much of people's lives, and having the ability or access to healthcare. What we know is when people don't have access to healthcare, they make decisions that have long-term consequences, or waiting until they know they have a problem, as opposed to having regular health care, which we can prevent difficult problems before they advance. There are no further questions. I'm shocked. I'll just talk about the really abuses of Medicare Advantage and the prior authorizations, which I think is really a scourge on the delivery of healthcare, because people have insurance and they should have access to the things they need. And the idea of using prior authorization to decrease utilization is a very pernicious practice. We had a oncologist who had a patient in PNHP who had a patient who they were considering surgery for, but the surgeon wanted to have a PET scan before doing the surgery to make sure that the cancer had not spread anywhere, because then it would not be as beneficial to have the surgery. And the PET scan was denied. And it took 6 months to get approval for the PET scan. And by that time, the patient had died. So this is really a practice that we need to address. And I think that fighting the privatization and battling the abuses of Medicare Advantage is very important. Monica, I don't know if you want to comment more about it.
Oh, I could talk about Medicare Advantage all day. I mean, most of more than half of the patients I see are Medicare Advantage patients these days, because I'm an internist. I see mostly adult patients above the age of 65. And I think that I can see it affect my practice in a very real way, because the documentation burden for Medicare Advantage is massive. They're making doctors do more and more and more paperwork to justify everything that we order. And so, I mean, my nurse spends pretty much her entire day just filling out what we call prior authorizations, which means getting patients like tests, medications, scans approved, which is really like such a horrible utilization of resources. It's just bogging down our entire office. Our hospital recently severed their relationship with one of the Medicare Advantage plans because of this issue. It's just so it doesn't just affect the patient, but what it does is it overwhelms the healthcare team, so that we can't really do anything else besides like do all this paperwork that nobody has time for. So thankfully we are starting to get members of Congress aware of a lot of these issues. So a lot more members of Congress are speaking up about Medicare Advantage and the harms and the issues related to the plans. But, you know, on the flip side, the issue is that Medicare Advantage does a really good job at figuring out how to sell to patients, how to lower monthly costs for the patient, so it looks like a good idea up front. So we need to really be thinking not just about pushing back against Medicare Advantage, but again, like that, creating an overall better solution for our seniors, like a universal healthcare system. Yeah,
Right. So many seniors signed up for Medicare Advantage, and you know, I've even had this conversation with family members because Medicare Advantage offers coverage for vision, dental, and hearing, which traditional Medicare does not. And so people with Medicare Advantage think, okay, I'm going to be able to get eyeglasses, I'm going to be able to get hearing aids, or I'm going to be able to get dental care. But what you don't know until you're into the plan is that there's so much money in each of these buckets, but the dental care that's provided may not be the dental care that you need or require. And so it is true that, you know, patients with traditional Medicare don't have those coverages. And that's because if we look at when we started with Medicare, those weren't the biggest things. And I'll say that the initial plan with Medicare and Medicaid was that we would eventually cover everyone, but they started with children and seniors because they thought, who could be against that? Who could be providing access to care, and that it would become popular, and then it would move on to cover everyone. But we never got there, and the financial barriers are tremendous. But there are a lot of rural hospitals that have just stopped accepting Medicare Advantage plans because of the delays in payment. And as a result of that, there are huge swaths of the country where um, people who are in Medicare Advantage plans don't have any providers within a 100-mile radius. And if survey of the administrators of these rural hospitals, there have been over 100 hospitals that have closed, and they cite that the delays in payments and the obstacles that healthcare providers have to go through to get um, paid for services provided is the major reason for that. So
Yeah, I think that like there's a great question about why are patients choosing it. I think Claudia, you did a great job getting to why some patients choose it. I think also like yeah, I was just helping one of my coworkers. Her mom was in this space, and she was asking me. We were looking at it, and oftentimes the monthly cost for a Medicare Advantage plan is lower than getting a Medicare plus Part D plus Medigap. And that's a real consideration that patients need to consider. This patient, is either going to be like $20 a month with an Advantage plan or like 300 to buy the Medigap and the supplemental and the Part D. So, on the surface, it looks like, it makes a lot of sense. And I understand a lot of seniors can't afford that extra $200-300 a month. So,
want to fix.
and that's why the disproportionately low income families are on Medicare Advantage. Um, and so my rule is I tell everyone, if you have to pick an Advantage plan, you're not a bad person. I understand. And it's like totally fine. What we have to do is from a systems level is fix the issue. Um, and then I'm also going to just quickly answer this question about the state of Illinois because we have somebody doing advocacy on that. So there's a question does the state of Illinois automatically enroll people? So we actually have one of the physicians on our board was from the University of Illinois, and he found out that through him retiring, that all people who are state of Illinois employed are automatically, as of a couple of years ago, when they hit 65, being put on a Medicare Advantage plan. We are not sure how that negotiation happened at the state level, but there was basically like a state memorandum, and it's kind of unclear. But we do have somebody on our team who's working on that advocacy. And we've had some successful meetings in Springfield about this. So if you are somebody who works at the state or is, concerned about state retirees being put on Medicare Advantage, definitely like shoot me an email. We can connect you to some of the advocacy we're doing on that.
That was a huge issue in New York, where the
Yeah.
state attempted to force retirees into Medicare Advantage plans, and the employees fought back against it successfully. But it was a huge campaign tried to do. Bill, you wanted to make a comment? You're on mute, Bill.
You mentioned that several hospitals in some rural areas are not taking Medicare Advantage because of the payment delays or the denials, probably. I wonder if we can get stories from people there, if we can document this and publicize it more, because I think that will certainly give people pause before they sign up for Medicare for All. If they think their local hospital is suddenly going to disconnect them, I mean, that would be terrible. They have no coverage at all then.
Well, we're actually working with Congresswoman Jayapal on this. She's going to be submitting a letter to members of Congress, and that's one of the issues that she's addressing about the issue with rural hospital closures as a result of the Medicare Advantage. And there was a question about was it illegal to use Medicare in the Medicare Advantage plans? No, this was approved by Congress. They've been licensed. Um, and it's basically selling or allowing the privatization, a stealth privatization of Medicare.
I had another question about I think there's a lot of power to be gained by working with other groups in unison with other groups. And the work against claim denials seems to be very important because, for one thing, it affects everyone, not just seniors. The other thing is if we can reduce the number of claim denials that insurance companies can use, we weaken them. We weaken them financially because that's very important. And by weakening them financially, it makes it easier for us to get Medicare for all. So if we think about it from that way, the claim denial effort is the anti-claim denial effort is an important one, and I think we should be thinking of ways that we can work with groups like People's Action to advance that in Illinois.
Is that your response to the question about the national single payer? And whether Illinois Single Payer Coalition partners with national?
We don't, and I think that's a weakness in our movement that we're not working more closely with them. And, I'm going to try to reach out to them, particularly if they do sponsor the March on Washington. I think that will be great for all of us to get involved in to the extent that we can.
I'm just going to say for Bill's behalf and because I've also been involved with the Illinois Single Payer Coalition, but recently just stepped down, but it's an entire volunteer-based board. So we do what we have capacity for. So the more of you that are energized by this call, this talk, and want to get involved in this work, definitely consider hopping on one of our organizations, PNHP, Illinois Single Payer. We work a lot together, so you can sort of pick one based on your interests or you can pick both because we do a lot of overlap, but we all find time in our spare time to do this work. It's volunteer based. We're working on getting more of I know the Illinois Single Payer Coalition hiring someone. PNHP, we do now have a big team of national organizers, and we have student organizations around the country that are also really involved in the movement. So yeah, the more people, the bigger we can build this base, the more successful we will be at all these ideas you're all throwing on the table. A lot of times people have great ideas, we just can't do them because we don't have enough bandwidth.
Yeah, someone says that Medicare Advantage incentivizes under utilization and that traditional Medicare incentivizes over treatment of fraudulent billing. Although I think the statistics will show that the number of unscrupulous physicians who over bill has been really overestimated. But the point is that and what we're witnessing right now is the dismantling of inspector generals and the quality improvement processes that we put in place to ensure that people receive appropriate care. And it's important to understand that there are, certain standards in terms of treatment, and it is the expectation that medical staffs also provide some oversight into the quality of care. I spent years of my career providing oversight to the delivery of care, and we try to ensure that people provide the care that patients need in an appropriate fashion. But there's no easy solution. Some folks would say, well, not having fee for service, that having employed physicians. I'll tell you that the majority of physicians in the United States today are employed, are in an employment arrangement because it became financially unviable to be in private practice. And so there's very little private practice left in the United States. And so when you have even large employers, it's important to make sure that they are not directing away from care and toward profits. And so it's how we compensate physicians has a lot to do with how that plays out. And we have a question about tactics. We have a base of support, but people don't have the time or agitation to fight at the level we need. We saw most of us fired up. See, fired up this country and got was a round of violent tactics. What could be successful and disruptive and nonviolent and direct action look like? I think it's important, and Monica, you may want to speak to this as well, is that when physicians talk to legislators, it makes a difference. When they're physicians from their districts, it makes a difference. And so it's really having those conversations and reminding legislators that they're supposed to be working for the people and not the health executives who are lobbying them.
Yeah, I mean, I think kind of like uh, I think that there's not one single tactic that is going to achieve this. I think it's going to be multiple, multi-pronged tactics on multiple fronts pushing this forward. We have the most friendly Congress we've had in a while in a funny way, because while, the Republicans have their, slim majority, we do have a lot more progressive Democrats who have signed on to the Medicare for All bill. And so it's really just continuing to put pressure on them and their communities and their districts with corporations, with unions, and having these meetings and pushing people in the right direction. And like Claudia said, from our end, we really do have a lot of successful meetings with legislators who like to hear from doctors and nurses and hear their perspective. I should mention that National Nurses United, which is the largest nursing union in the country, is very supportive of Medicare for All, and we partner with them on a lot of things as well. So, I think that I'm going to go back to what I said earlier. We need to just continue to build that strong base and push this forward, even if it's financially unpopular for our two big, corporate parties, which get a lot of corporate donations. We need to keep the broader we can build the base, the more likely we are to successfully push them.
There's a question about PNHP having chapters at all the Illinois medical schools.
Yeah, we have chapters at almost, I know we have at Loyola, UIC, Northwestern, Chicago Med School. So I think we have most of the big ones in the north side of the state. I'm not sure the status is of the southern portion of the state. We do have a national organizer who's working on all of that. So we do have that is one of the big goals of PNHP nationally, is getting student chapters in as many schools as possible.
Yeah, we do have SNAP chapters, and I think downstate as well. And so there's a question about RFK and what we expect the impact of RFK to be on HRSA and the impact of Medicare Advantage. I think that RFK will be a disaster in a number of ways. I think that he poses a real threat to immunizations, and there's a lot of concern about that. More than so than RFK, it's really if RFK goes through, or even the plan is to put Mehmet Oz over CMS, and that man has had over $30 million in stock in private insurance industry, and he's already supported making Medicare Advantage the default. In other words, that everyone who turns 65 would automatically be put into a Medicare Advantage plan. So PNHP is actually planning to have a shadow hearing discussion about Oz on the day that he would go before Congress for approval to be the head of the Centers for Medicaid and Medicare. I think he's a more imminent threat to not just Medicare Advantage, but the delivery of healthcare, Medicaid and Medicare in the United States. And I don't know if Monica or Bill have any questions about that, but this is
Yeah,
really
nothing but badness is going to come out of these nominees. I mean, every single one of them is worse than the one before. But what do we do? Here we are. We're stuck with these people. We got to continue to do what we can around them. It is a big point of our, PNHP. We are fully aware of the threat that RFK poses to national healthcare, not just healthcare financing, but public health as well. I don't have anything to say other than it's going to be a disaster. We're going to have to work around it. We've had people in national offices, and we've had appointees in other divisions in the history of our country who have represented a threat to social justice and civil liberties, and we have to work around those people. So take all this energy that you all have in the chat and these questions, like bring it to a cause that you care about. I think it's going to be an overwhelming few years. I mean, he's only been in office for a month, and like think about all the barrage of emails and news alerts, and my phone won't stop beeping with news alerts and texts about what's happening. So I think that we have two options. One is we can be just paralyzed by like this onslaught of attacks from every direction, or pick one cause. For me, this is my cause. I'm going to fight for it. I'm in an organization that's advocating for it, and I'm going to focus my energies there. I can't fight against everything that's happening all at once, but I can work in this space. So I encourage everyone on the call to do the same. Pick your issue. If it's Medicare for all, join us. If it is immigrant rights, if it is trans healthcare, if it is gender equity, if it is women's rights, if it's the right, voting rights, there's a lot to work on. Pick your cause and find an organization that's doing the work. Don't start on your own. Find an organization that's already in that space and get involved. And it's going to take all of us to really push the envelope forward. The last time Trump was president, we actually, at the end of his presidency, made groundwork on progressive activism, because we didn't have we all knew that Biden wasn't going to pass Medicare for all. He wasn't really support for it. So we kind of just had to work with his admin, work with the moderate Dems, do piecemeal reform, push back against Medicare Advantage. But when we have somebody who's so radical on the right, it allows us to push radical progressivism as an agenda, and we should all get on board with that. So that's my speech for the day. I know Bill's got his hand up. I'll let you talk.
Yeah, Bill. And the other thing, Bill, is there's a question from someone who lives in Kane County, who had home in Elgin and Aurora, and they want to know who is to work with to create a Medicare for All resolution to bring it to the Kane County Board.
Okay, I can't give a name right offhand, but if you send me an email, I will look up and see who our supporters are in Kane County. And I think there are some activists who would be willing to take that on. And I'll have to get back to you on that.
And then you had a question, or you wanted to?
Yeah, from what I can tell about these appointments, and our good friend, what do they call him? Felon Musk? Put an F on front of his Elon. Anyway, is that they're going to attack Medicare, Medicaid, and all other government programs. They're going to say, yes, it's terribly expensive because of government inefficiency. And so therefore we need to privatize it even more. And so that lie is going to be, front and center on all programs that are, all public programs. And so I'm wondering, is PNHP, does it have any plans to do any advertising to counteract that? I mean, to tell people right up front, it's not the government that's inefficient, it's the private insurance that's terribly inefficient. And I feel like we're kind of missing the boat on getting the message out to the general public.
Well, right. I was going to say, when Monica was talking about it, one of the important ways to combat this is to shine a light on it and what they're doing, because a lot of these decisions are really based on profiteering, of providing more profits for Donald Trump's billionaire friends. And the whole issue with Medicaid, and there's a question about how are we going to be protecting Medicaid as it's being threatened. And so one of the things in Project 2025 is they said that they wanted to balance their reform of Medicaid funding with balanced match grants. So right now the feds provide 65% of the total dollars spent in Medicaid, and although they don't say equal it to 50%, what it will result in is cuts in Medicaid, and capping their plans to cap the absolute number of dollars spent on Medicaid. So it's important for us to shine a light to make people aware of the impact, because right now people who they do focus groups. They did focus groups on folks who voted for Trump, and they're happy with him, and the people are supportive of him because they see something happening. They see him visible, and they see actions. They don't necessarily understand how these actions will impact their daily lives. They don't understand, so a lot of people who supported Trump don't understand how these decisions are going to hurt them. And so it's important to put these out, to make it put it into the public sphere to help people understand the impact of these decisions. And so the idea that the balancing Medicaid funding with block grants and caps, that Medicaid, the idea would be that Medicaid would get less federal dollars. And in some states, and what people don't understand, when we're using federal dollars, it means that states like Mississippi and Alabama, which are poor, actually are getting more of a return on their dollar, and that wealthier states like Illinois get less because those poorer states have less to provide, and yet they have people in need. And so these changes will have dramatic impact on what happens. And so while we don't use commercials are very expensive. We do have plans to publicize this to make more people aware of the impact and to shine a light on really the nefarious actions of not just Musk and Trump, but all of the players that he's bringing into government. So yes, talking about it in many different venues and places to make people, yeah, and Monica's right, people get paralyzed because they're overwhelmed, but it's important to shine a light and talk about the impact of these various decisions, which seem to be, talking about balanced funding, talking about reform. Those all sound like positive things, and yet they're very nefarious plans that they have in mind. Which includes, yes, they're talking about the cuts in the House Budget Committee, talking about $900 billion in cuts to Medicaid over the next decade. And that's going to happen by really hurting people who need it the most. And I don't have any more open questions. I think that this has been a really good discussion. I hope that it's provided some useful information to the people who have signed on. And I'll like to give an opportunity for Monica and Bill to give closing statements.
Okay. Well, I just want to say is that I guess we all have to think of ourselves as leaders in our own little area, our own little corner of the world. And I know that's kind of a big step for some people, but there's a lot of help and a lot of direction out there. And you find that once you reach out to people and you reach out to legislators or church leaders or whoever you're reaching out to, you'll get a lot of confidence after a few meetings. So we don't need to hesitate on that score. And we hope that you get involved with one of the organizations, and there's many of them, and they all seem to have a pretty good angle on what they're working on. So, but the ultimate goal has to be for all of these organizations at some point to collaborate and to work on one or two big issues. Maybe that's down the road for a few years, but I hope that's where we're going.
Thank you very much, Bill Bianchi. And Monica Maalouf?
Yeah, thanks, Bill, Claudia, and thanks everyone for being on the call today. I think I'll just echo what I said before, which is just that, I think it's someone put in the chat, it's only been 24 days. It's going to be a long 4 years. And so, focus on an area of advocacy that makes sense for you. Realize that your voices do have power. We have, like I said, already with just social media, with outreach, with pushback, there's been so many lawsuits that have really put a lot of roadblocks in front of Trump and his agenda. And so just imagine what we can do if we can get all these people, all this energy on board with things related to healthcare reform. I think we have real opportunities to push the needle a little bit here. So don't be deterred that the fight is a long one. And thank you all for being here today. And I'll put in the chat, but I'll just put it again. I'll put my email, my Blue Sky social, and then the PNHP website.
Yes, thank you. I want to remind everyone that knowledge is power, and that all of the information, the facts, and the data I presented today is available on the PNHP website at pnhp.org, and that this is a long struggle. I've been doing it for I hate to acknowledge that, but for 40 years. But we have seen progress. And it was a time when I would talk about single payer and people had never heard of it. And now people have at least some semblance of knowledge about it. I think that it's in a struggle we continue. And I think that there are people who, who are interested in participating in it. And I think that we have opportunities. And sometimes when things look the darkest are some of the greatest opportunities to make an impact and make a difference. So I hope that we provide you with some information that you found to be useful, and you will join us in this struggle. Um, that there are a lot of people out there who are suffering as a result of our lack of universal health care, and that it's a fight worth joining. So health and medicine will continue to advocate on the state level as we have for more than 40 years. And we are happy that you took the time to join us this morning. And with that, we'll close. And thanks again.